What's the best functional stool test that I recommend every week in the clinic? Hey folks, my name's Todd Mansfield. I'm a clinical herbalist here in Byron Bay, Australia, and today we're talking about functional stool testing. My favorite, the one that I recommend all the time. Sometimes I'll review maybe 5, 10 of them in a given week in the clinic. Functional testing is complex. It's important to understand the basics. I've talked about my favorite for chronic complex diseases. You can find more about the OAT test here. I do a lot of SIBO breath testing, very commonly recommended in the clinic, and functional stool testing, which we're going to be talking about today. The stool test is actually called the Complete Microbiome Mapping. It's available here in Australia. You can get it in New Zealand as well. If you are living in Europe or you're living in the States, I also really appreciate the GI effects from Genova Diagnostics. So why is it important to test? Why don't we just treat? We know there's digestive dysfunction. I'm going to go through, I'm going to pick out the really relevant and actionable data that I see on the Complete Microbiome Mapping. There's so much of the chemistry of your digestion that can become dysregulated, and huge point, most important point, actionable data. Like, is it something that we can action and get benefit for the patient? So let's jump into it here. General macroscopic description. Don't find this is so relevant. Stool color, stool form. Mucus, a little bit more actionable. A lot of inflammatory bowel disease patients will report mucus in their stool. IBS patients, irritable bowel syndrome patients, will report mucus in their stool. It's generally a marker of inflammation and gut damage when it's excessive. Occult blood, FOB, fecal occult blood. This is a big marker. And if I see this kind of positive on a patient, I am going to be referring them back to their general practitioner, their doctor, and getting them worked up. And there's a few other pieces here where we say, look, that's a referral back to a primary care physician to get assessed. GIT functional markers. So right here, calprotectin, this is a pretty actionable piece. I've got another video on reducing significant calprotectin in 2 or 3 months by treating the root cause. You can check that out here. Right here, 4.6, this is extremely low calprotectin. This is a marker of inflammation in the digestive tract. And 0 to 50, anything above 50 I'm going to take more note of. Anything above 200, that's going to be a referral back to the primary care physician, get evaluated. The higher that gets, the more concerned I am that someone's dealing mainly with inflammatory bowel disease, for sure. Pancreatic elastase 1. This is a huge marker and gets ignored frequently. Patients come to me and sometimes they have these labs, sometimes they've been working with other practitioners. Pancreatic elastase, 202. The cutoff is 200. That is a smoking gun. Do not ignore that. Anything lower than that, I would refer it, if that was red, I'd refer back to the primary care physician, mainly to get elastase 1 ordered again, mainly to get them kind of clocked by Medicare and kind of on the books with their GP. And right there, I would be looking to get a diagnosis or get evaluated, it's a better way to put it, of exocrine pancreatic insufficiency. So if you look that one up, there's all these symptoms associated with EPI, weight loss, and digestive dysregulation, and possibly some kind of sinister causes. I don't find that's the case for most patients, but I do find really kind of anything below 200, definitely want to treat actively and directly. 200 to 300. Still probably in that kind of gray area where we want to trial them on an enzyme therapy, a strong digestive enzyme therapy to see if we can make some impact on their digestive symptoms, see if we can improve them. Anything above 400, irrelevant. Anything above 500, that's really their cutoff, 500 or above. That means that their pancreas is producing digestive enzymes appropriately. you can rule that out, which is huge, 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 huge. Not having a condition and having a test show negative for that condition is just as valuable as the test saying, yep, you do have exocrine pancreatic insufficiency, or better put, there are markers indicating it. Go back to your doctor and get evaluated. Fecal secretory IgA, I don't find this is the most robust marker. This one's 414, the cutoff is 510. I would be looking for, a much more suppressed secretory IgA. That's kind of like the immune defense in the gut. Patients who are dealing with chronic digestive health symptoms, they've been at it for a while. It's not a surprise that their immune defense is low, and there are even some kind of genetic presentations where they can't mount a secretory IgA defense in the gut. So that's important. It's not really that actionable. It wouldn't change my, my treatment plan. We kind of clock it. Fecal secretory IgA, moving on to fecal zonulin. Zonulin is huge, huge, huge. If we're talking about gold standards to test for leaky gut, intestinal hyperpermeability, where the gut lining becomes more permeable than it should, allowing things that shouldn't cross into the body from the gut. There's the lactulose mannitol test, which is a lot more kind of robust. Early on in my practice, I did a lot of side-by-side testing of zonulin that we can find here, and the leaky gut test, lactulose mannitol, and I did see them match up, almost 100% of the time. So there's a little bit of a gray area here. They say 107 or above. I mean, I am taking note of it when it's even in that yellow kind of zone, 90 or above, 85 or above. I'm saying, look, there's probably some leaky gut happening. We want to know why. We want to treat it. And if your symptoms aren't improving, even if we retest and all of the bugs are gone and the kind of predisposing factors have been resolved, I would do a leaky gut test, like a proper gold standard lactulose mannitol test. Fecal beta glucuronidase. So again, this is a little bit of a kind of non-specific marker of gut imbalances. The higher this one gets, the more we can see this kind of dysbiotic or imbalanced bacteria. And the big one that's happening here is this is kind of reversing part of your phase 2 detox process, glucuronidation. And one of the really big pieces here is estrogen. Estrogen kind of conditions, or conditions that are driven by excessive estrogen. So everything could be working out perfectly. All of your kind of phase 1 could be working perfectly, phase 2 could be working perfectly, you could be having great bowel movements, so where's this kind of estrogen coming from? And unfortunately, when this is high, the gut bugs there that are producing this little enzyme can reverse that estrogen detox plan, send estrogen back into the system, kind of doubling down. Steatocrit. Huge, 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 massively actionable data. The higher this is, means the more fat you have in your stool. Generally, it's pretty straightforward to see when this is severe, and I've seen this up in the kind of 30s. Watery bowel movements that float, bowel movements that have a little bit of a kind of greasy sheen to them. That would be common symptoms of fat malabsorption. Anti-gliadin IgA. I mean, I would, if this is redlining, I'd definitely pay attention to it. I don't see this elevated frequently. Microbiome mapping summary. So summary, let's get into the details when we actually see these bugs as we go through. Key phyla microbiota, again, what's driving that Firmicutes up? We're going to find out farther down in the plan, in the test, sorry. Parasitic organisms. So, if we're looking at these ones, I would pay big attention, root cause drivers, Cryptosporidium, gotta go, get rid of it. Entamoeba histolytica, gotta go, gotta get rid of it. That's a big one, that's a significant parasite. Giardia, gotta go, gotta get rid of it. So I kind of really like how they've laid these out. These ones are questionable. And look, I do see them frequently. They are very, very common in my patient population, particularly if they're in the local northern rivers kind of region, around Byron Bay, Mullumbimby, Yukai, Nimbin. A lot of people are drinking tank water, and these little bugs, they can kind of get infected with them. And some patients that have been living here forever, they might have had it their whole life and their digestive symptoms might be new. So I really would not prioritize those two if there were other really significant pieces. I would definitely put so much more weight on that low enzyme production from the pancreas than I would a blastocystis or a dientamoeba positive test. I know that's controversial. Worms. Like I say, I've looked at hundreds of these labs, maybe thousands, haven't counted them. I have never seen a worm once. Maybe they can't test for it well. I'm sure there are worms. I don't think this is really significant here in Australia. Maybe if you're traveling in third world countries, that might be more of an issue. Opportunistic bacteria, valuable section of the test. I would love if there were a couple more here that I am always questioning whether they're root cause drivers. We'll talk about them when we get to it. We've got some of these ones. I don't frequently see these ones elevated, maybe 10%. Morganella, pretty potent histamine liberator. Pseudomonas, strong driver of gut symptoms, very pro-inflammatory. Damage the gut lining. There we would be looking for a zonulin marker to be a bit higher if that was really damaging it. Staphylococcus, I see it occasionally. Streptococcus, I see this one not this high, but I definitely see it redlining in the vast majority of my complete microbiome mapping tests that I review. I don't put too much stock into it. I don't know if their probe is inaccurate. I don't know what's going on. I don't think it's a huge driver. There's some kind of issue with this test. So, if that's the only thing that's redlining, maybe. Methanobacteriaceae, methane, one of my favorite subjects. Talk about this all the time. Very passionate about this subject. 6.8, cutoff is 5. I find that this stool test completely underreports the methane, or maybe more accurately put, a small amount of methane on a stool test can produce a mega amount of methane gas. It can be really active, producing a ton of gas. So that's where I would be looking for a breath test. And if a patient came back with this result, I would be pushing to get a breath test just to get methane numbers on the page. That could be 10 parts per million. Not really that relevant. That could be 100 parts per million. Mega methane. I've seen that maybe like 5 or 10 times in my career. Desulfovibrio, that is a sulfur-reducing bacteria, an SRB. It's a pretty significant one. I would put good stock and good focus on reducing that if it was elevated. The one sulfite-reducing bacteria, sulfite or sulfate, really important. Bilophila. I would love to see Bilophila on a complete microbiome mapping, and I am waiting for the day for that to come. If we're talking about hydrogen sulfide gas, those are the two mega hydrogen sulfide gas producers, and they can be very stubborn and they can be very hard to pin down. So really, once we get that one on this lab, this will be so great. Oxalobacter formiginans, this is an oxalate degrader. I have seen this quite low on some patients. I think it's quite sensitive to antibiotics, so this is a really relevant marker as well. Most of these guys right here, potential autoimmune triggers, most of them are gram negative and they are pro-inflammatory. That's probably why they have them marked under autoimmune. I don't find it's that relevant to kind of drill down to the species. If I'm seeing, kind of brothers or maybe cousins or like closely related in the same family, Enterobacteriaceae, bit of a mouthful there, I will kind of suspect that there are more. Because again, we're not testing for all of them. This is definitely missing a whole chunk of the microbiome. But I think we can make a good guesstimation And the big piece here, right? Data that's actionable. How is it going to change your treatment plan? Herbal medicine, natural therapies, gut balancing plans, they're going to be addressing more than one factor at a time, right? So we're thinking holistically, how can we bring the gut back into balance? Fungi and yeast. I find, and again, you might disagree, if you're a clinician or someone that really knows the gut listening out there, I find that stool testing massively underrepresents the fungal load in the body, whether that's the small bowel, it's probably mainly the small bowel. So again, if you see this, I mean, this is just through the roof for 41.7. I would think that is an extreme marker. I don't think I've ever seen Candida that high. I would prioritize that very specifically. If I was suspecting that a fungal overgrowth was driving symptoms initially, I would be pushing for an organic acids test, a strong recommendation. More on that here. Moving on, we've got the bacterial pathogens. Again, if we're talking about things that we want to balance, which would be more of this section right here, you know, a little bit of this in the tank is fine as long as it's balanced with good guys and kept in check. Most of these guys, every one of these guys, they have to go. We gotta kill them. We gotta move them on. And I know that's a bit of an aggressive way to put it, but you know, we don't want to beat around the bush here. I can think of a number of different cases, but one very specifically, it was an older gentleman and he had been dealing with watery bowel movements for years. He had been worked up and down by his gastroenterologists and specialists, and you know, I think he'd seen an endocrinologist and you know, all these different kind of tests, colonoscopy, endoscopy, this, that, the other, negative, tick, you're all good. I'm not all good. I'm experiencing watery bowel movements. I'm losing weight. I'm having a problem. That was the kind of conversation. And so we said, look, we got to spend some money. We got to get this complete microbiome mapping in. We got to follow up as quick as possible. And he came back with a pretty significant Aeromonas infection. And you know, I know Aeromonas. I don't see it frequently. I've treated it before successfully, but it's synonymous with watery bowel movements. And I think that was just a glaringly obvious missed test from his primary care physicians for sure. Just running a standard DNA-based stool test from the doctor would have clocked this Aeromonas species. A couple other big ones. We've got some toxins from C. difficile, very valuable. Rarely see it. I do see a decent amount of pathogenic E. coli's, strong drivers of gut dysfunction, leaky gut, inflammatory bowel disease, virulence factors from H. pylori. If we're testing for H. pylori, I prefer testing the breath. That's a much more accurate, that's my recommendation, rather than the stool. Definitely not the blood. It's not telling you if it's an active infection. They're looking at your antibodies to H. pylori. Never seen a viral pathogen once, so I don't know what I'm missing there. Patient population might be, you know, a bit unique there. Normal bacterial gut flora. This is valuable. There are some pieces that are important. It's not really going to change my my approach. Big pieces here: Faecalibacterium prausnitzii, all-star superhero of the gut. We want that up for sure. Your bifidos. E. coli's gram-negative if it's elevated, you know, even if it's not an overt pathogen like this one up here, you know, we got to bring it down and rebalance it. This bottom piece right here, you know, the test is probably just shy of $400 Australian dollars, so, you know, it's not cheap. If all we got was this first page, particularly the GIT functional markers, and this last little section right here, short chain fatty acids, I would recommend spending the money. Such valuable, actionable data. I frequently see low butyrate, high acetate. That's a common presentation. Lab low butyrate just means the gut, the large bowel, is not being supported, and we do not have our beneficial bacteria in sufficient numbers to keep everything happy, to keep everything in check, to heal the gut lining, to keep it nice and acidic so that unfriendly bugs don't proliferate. And that is just such actionable data. We want to be feeding beneficials, even if these guys look fine, you know, Lactobacillus, Bifidobacterium, F. prosnitzii. There is a whole raft of butyrate producers that haven't been tested for here. And if that is low, we need to get them up. If it's lab low, we might even start on a straight butyrate supplement just as a little band-aid to help balance the gut. As a bit of a deep dive into the Complete Microbiome Mapping test, this is the test that I would recommend if I'm suspecting there is large bowel dysfunction, and also if there is any kind of chemistry imbalances in the digestive tract, leaky gut, poor pancreatic enzyme production, fat malabsorption, such valuable data that can really make some huge inroads on patient symptoms, get some progress, heal everything up, rebalance, and if there are any bacterial pathogens or any of those parasites that we mentioned that are more strongly related to symptoms of gut dysfunction, often acute, really strong symptoms, they need to be eliminated. So we'll be much more aggressive with our treatment up front to clear out that gut, and then work on rebalancing and remodeling and bringing everything back into homeostasis. So I hope that helped. Like the video, leave a comment, don't forget to subscribe. And if you are looking for digestive health symptom support, you live in Australia or New Zealand, then reach out to us here at Byron Herbalist. I'd love to hear from you. We'll see you in the next video.